So my name is Eric Wallace. I'm a nephrologist at the University of Alabama at Birmingham. My work in lysosomal storage disease is really all Fabry disease. So I run the rare genetic kidney disease clinic at UAB, but the primary focus of that clinic is really Fabry disease. So Fabry disease is a lysosomal storage disease that stems from a deficiency in alpha-galactosidase, which is a gene that, or it's an enzyme that breaks down globotriaosylceramide, and it's in every cell in our body. So as that gene fails to break down the globotriaosylceramide, you get end organ damage, which primarily is the brain, the heart, and the kidney, and it affects everything. So these patients not only will get early onset strokes, white matter disease, which is memory loss, they'll also get hypertrophic cardiomyopathies and heart failure and kidney disease, but on top of that they present typically not with the end organ disease, but with symptoms like severe pain in their hands and feet, and GI symptoms, which are usually the presenting symptoms. They'll also get angiokeratomas, which are these little purple spots that are on the skin. Some people have them, some people may not, and they'll get these what's called corneal whorls, which is inclusions in the eye that you can only see when you go to an ophthalmologist. So it really affects a lot of things. The good news is we have treatments available as long as we can diagnose the patients early enough. That is a great question, and I think it's one that's becoming even more relevant now that we have more treatments, because it used to be from 2003 until 2018 we only had one treatment. In 2018 we got Galafold or migalastat, which is the chaperone therapy. That's relatively easy because migalastat is only indicated in certain what are called amenable mutations. So these are mutations that the patient in general makes some of the protein, but it just doesn't fold correctly. And so what migalastat does, it actually helps the folding of the protein so that the enzyme that you do make actually works better. So in patients with amenable mutation, the other thing about migalastat, it's oral. So typically if it's an amenable mutation, what we'll do is we'll start the oral migalastat. If it's non-amenable, we'll start enzyme replacement therapy. Now there are two enzyme replacement therapies. So one of the enzyme replacement therapies has been around since 2003. That has a half-life of around 2.5 hours, and we only give it, so in general half-lives, it takes 5 half-lives to get out of the body. So within 10 to 12 hours, we've given the enzyme. 12 hours later, you can't detect it in the bloodstream. So, and then we don't give it for another 2 weeks. So there is another enzyme that got approved, and that is pegunigalsidase alpha, which is a pegylated form of the enzyme, which has a much longer half-life. So in trying to choose between those enzymes, some of it depends really on the patient characteristic that you're treating, and the other has to do with the tolerability of the enzyme, where pegunigalsidase alpha has been shown to have lower infusion reactions. But there's still some questions as far as who do you treat, and some of this is the data available on each enzyme. So there's still very difficult decisions on how to choose which treatment for which patient. The bottom line of the presentation is that it's very difficult to compare treatments, because although pegunigalsidase was compared in a randomized controlled trial to agalsidase beta, the question is, well, what about the other treatments, specifically agalsidase alpha and migalastat? And so if you don't have randomized controlled trials comparing each and every therapy, it becomes very difficult to make conclusions. So this was an attempt at trying to compare studies that have not occurred, which is pegunigalsidase alpha to migalastat versus pegunigalsidase alpha to agalsidase alpha, to really see what are the treatment comparisons when we are looking at specific parameters, right? So left ventricular mass index is what we were specifically comparing this across the treatments, because those weren't directly compared in the randomized control study. So in order to do these studies, what you do is you have to pick certain studies that have already been done that measured the effect of one drug on, in this case, left ventricular mass index. So what we did, we looked at pegunigalsidase alpha versus agalsidase beta at specific doses that measured left ventricular mass index. Then we looked at other studies and we networked these studies to say, well, what are the studies that looked at migalastat and left ventricular mass index? What about agalsidase alpha and left ventricular mass index? Where there were comparisons between each one, but not together. So this is called a network meta-analysis. The results of the network meta-analysis showed that there was a nominal trend favoring pegunigalsidase alpha as for left ventricular mass index as composed to the other treatments. However, none of that was statistically significant. So as a clinician, what I can say is that at the bare minimum, pegunigalsidase alpha is comparable with respect to left ventricular mass index to the other therapies, since there was no statistical significance. But this type of trial there's a lot of limitations, which is it's not the same patient population. So although when you have limited data like we do in rare disease, you do the best you can with the data that's available. So these types of trials are trying to make heads or tails of all the data that is available, but ultimately there's big limitations, which is that the trial populations in each one of these trials was not exactly comparable. So that's when you try and do statistical methods to limit covariates and things like that. But ultimately, when rare disease, we have to do the best we can with the data we have. And so the data showed that statistically these were comparable, but there was a nominal favoring of pegunigalsidase alpha with respect to left ventricular mass index. I really think the biggest take home without statistical significance is that pegunigalsidase is comparable to existing therapies for Fabry disease as it relates to left ventricular mass index. The first thing to know is you got to diagnose it. So and this is just for all rare disease, when things aren't making sense with common diagnoses, you always have to think about the rare disease. And so what a lot of physicians do is they say, oh, it's too rare, so it can't be Fabry disease. But the reality is that this is not a disease you want to miss, because now we have 3 approved drugs. We have things we can do that can alter the life of the patient, their children, their children's children, and we need to diagnose it first. And I still think we're missing a significant amount of patients. And actually, we presented that at the American Society of Nephrology about how much we are missing the diagnosis. I think we're doing a better job, but the first thing is you got to think about the disease. The second thing is the genetic diseases you don't want to miss are the ones that have targeted therapies, and Fabry is one of those. So we need to diagnose it first. If you don't know what to do about it, send them to a center of excellence, and telehealth has gone a long way of improving access to patients who are not right next to a center of excellence. Now there should be no reason why patients should not be able to access a specialist in the disease.